most of the skin lesions actually already easily diagnosed by dermatology and also by plastic surgeon in some way. So for a few cases, maybe they want to see the depth of the lesion and also the spread and the pathology of the lesion if MRI can help. So we have some tips. Some cases courtesy to our friends, Professor Xu from Korea. Okay, so about the skin consists of 3 layers: the epidermis, the dermis, and the subcutaneous region. As we can see, the dermis contains quite a lot of vessel, nerve, and some other cells. And beneath the skin is the thickened layer of subcutaneous fat. And the thinnest is the epidermis. Most importantly, there are some cells we have to recognize. For the epidermis, we have very thin skin, like 0.5 millimeter to 1.5 millimeter. Actually, we cannot identify exactly which layer is epidermis, which is dermis, but we can easily recognize the subcutaneous area. So here's the sketch diagram for the skin. So we got the epidermis, the dermis, subcutaneous fat, more importantly, the fascia, deep fascia, and then the muscle. So we have to recognize the fascia, no matter whether it is superficial fascia or deep fascia, so that we can recognize it is actually from the skin, not from the muscle. So first of all, I would like to introduce a bit on the epidermis. Here, the important one is the melanocyte. As for the basal cell, is slow going if it is basal cell carcinoma, and the dermatologist can easily identify those lesions and even no spreading. But as for the squamous cells, is maybe spreading, but dermatologists also can easily be identified. But in terms of melanocyte, grow fast, easily spreading. So. Thank you. So case 1, 46 years old man, a palpable firm nodule in his left thigh for 18 years with progressive enlargement in 4 years. Here's the image. First of all, we can identify the spindle-shaped mass over here. And the first step for everyone is to compare the signal intensity, whether it is higher than that of the adjacent muscle or lower. So everyone can recognize it is higher. So differential diagnosis right now can be narrowed down to a certain substance, like fat containing melanin and macromolecular substance. So can anyone identify what I told the fascia, which is very important to differentiate whether it is come from the muscle or come from the subcutaneous region or come from the epidermis. So you have to go for the axial image. Clearly, the fascia is over here and a little bit elevating by the mass, and the mass invasion deep to the fascia, and with the compression to the muscle, not invade to the muscle. So in this case, we got higher signal intensity on T1 than muscle, and we have the fascia elevation, and it is clearly a tumor arising from the skin, and more precisely speaking, could be in the dermis or epidermis. So what is the diagnosis? You don't have the uvea? No? Okay. Clear cell sarcoma. Well, anyone have question? This is clear cell sarcoma. The finding is really typical. Higher on T1 with elevation of the fascia. So it is come from the skin. Okay, why is melanin bright on T1? Because melanin has a high affinity for the metallic ions like iron, copper, magnesium. All these are paramagnetic substances. And these ions are bound to the very complex group that leads to T1 brightening. And melanoma metastases have a propensity to hemorrhage. So melanin plus hemorrhage. And hemorrhage itself within 3 days is a type of methemoglobin. And in this situation, T1 brightening and T2 softening. So more than 50% of cases with melanoma display this typical pattern. Of course, the absence of this does not exclude the diagnosis. Okay, let's go for the second case. 31 years old man, palpable mass in his right medial thigh for 3 months. This is short. So T1 and T2, first of all, we should identify whether it is come from the muscle, from the subcutaneous region, or from the epidermis or dermis. Clearly, we can identify the separation by the fat and the well-demarcated lobulated lesion over here. On T2, purely is hyperintense signal with septation over here. And the septum is thin without any focal thickening or mural nodule or soft tissue mass. And after GAD, the patient didn't get any trauma. So we can see the wall of the lesion a little bit enhanced and very separable from the muscle here, right? So the diagnosis, you got it? Okay. Anyone? Myxoma. Well, okay. This is a clear lesion with fluid containing, very sensitive to fluid containing pulse sequence with septum. And it should not be abscess because we don't see any plurifocal inflammatory changes of the soft tissue. And it could be an epidermoid cyst, and the right answer is epidermoid cyst. And in terms of myxoma, there's a little bit different phases, and myxoma usually come from deeper layer. It's not exactly in the epidermis or the junction of epidermis and dermis. And we would like to see more soft tissue components surrounding the myxoma instead of just a purely very thin layer surrounding the cystic wall. So the correct answer is epidermoid cyst. So it is epidermoid cyst. So although epidermoid cyst could come from dermis because it is also termed sebaceous cyst. Okay, how about the dermis? Dermis we do have consists of vessels, nerve, and some fibroblasts and some other cells. So let's look at the case 3. 31 years old woman, progressively growing mass in her left thigh for 4 months. Okay, this is a larger mass, lobulated of the margin, heterogeneous signal on T2, if a tumor with homogeneous on T1 and homogeneous on T2, this should be benign. If it is heterogeneous on T2, it could be malignant and could be benign, but most likely malignant. Okay. But what we see is so many hyperintense signal vessels in the peripheral of the lesion. And the vessel is hyperintense signal because of the slow flow. If it is fast flow, it is relatively signal void or low signal intensity, right? In the center of the lesion, turn dark on T2. So it is highly cellular. What we call the NC ratio is high, the nucleus ratio to the cytoplasm. More nucleus, less cytoplasm on T2, low signal. Less nucleus, more cytoplasm on T2, high signal, right? So it is highly cellular and could be a malignant lesion, right? So the answer, anyone? We can vote epithelioid sarcoma, alveolar soft part sarcoma, MFH, and malignant PNST, peripheral nerve sheath tumor. Wow. Okay, the answer is epithelioid sarcoma. I'll tell you the reason. In alveolar soft part sarcoma, usually surrounded by fast flow blood. So if this tumor turn all the hyperintense signal to high flow blood, which is slow void or low signal intensity, then it could be alveolar soft part sarcoma. But in reverse, it is hyperintense signal. That means it is slow flow blood. It is quite typical for epithelioid sarcoma, especially for the skin tumor. So first of all, we have to identify whether it is come from the deep layer of soft tissue, like in the fascia, deep to the fascia in the muscle, but not it is come from the skin with peripheral hyperintense signal, slow flow blood, quite typical for epithelioid sarcoma. In terms of malignant fibrous histiocytoma, usually contains of three components: the hemorrhage, the tumor, the NC ratio is high, and also the hemorrhage. And for the malignant peripheral nerve sheath tumor, because of nerve containing, usually we can see the fascicular side. There's so many fascicles. We can see the Antony A and Antony B substance. And on cross-sectional image, we can see the target site with infiltrative margin. But in this case, it is not. So the answer is epithelioid sarcoma. The fourth case, 30-year-old man, incidental finding of a palpable mass in his right thigh. Okay, this could be much easier. Small nodular mass, clearly arising from the skin because we can see the thick layer of subcutaneous fat, right? Well-demarcated lesion, homogeneous on T1, heterogeneous on T2. If we can look detailedly, we can see the fascicles within the lesions, right? So many fascicles, but it is hard to differentiate fascicle from fibrosis. Usually fibrosis is rock-like, R-O-D, rock-like. Fascicle is like pepper-like. So in this situation, clearly it is a neurogenic tumor like schwannoma. Okay, great, everyone, almost 80% got the right answer. So I don't need to go further of this case. Schwannoma, the correct answer. Case 5, 40-year-old man, 2 palpable mass in his right thigh for 3 months. Thought 2 mass. So one is upper and one is lower here. But we can see the infiltrative margin deep to the muscle layer, even touching the muscle, and infiltrating through the epidermis of the skin, and even if we can see ulceration. So once the tumor is big, and then you can see the ulceration by the dermatologist or plastic surgeon, this could be malignant tumor. Okay, so a big tumor with ulceration, go for sarcoma. Okay, in this case of two tumor in two different sites, so it should be metastasis, melanoma. Melanoma is hard to say because it is a CT scan, but it is metastasis. Case 6, 17 years old female, a palpable heart mass and walking pain for 1 year. No trauma history. Here you can see the calcification along the subcutaneous fat on this profile, lateral view X-rays. I think you don't need to take MR imaging, but this case is already done, so it is easy. Yeah, it is hemangioma, especially those with cavernous hemangioma or venous type calcification developed. The histology is hemangioma. Okay, let's go for the last section, is the hypothalamus. Hypothalamus with quite a lot of fibroblast and adipose tissue, and also macrophage. So these all should be awareness. Case 7, 52 years old woman, the palpable mass in her left thigh. A little bit difficult. So let's see, the tumor is lobulated, cystic component, and not only one cystic, but 3 combined, union together. And in this situation, usually we ask for a plain X-ray or CT scan to look at any calcifications. And after that, enhance, and the signal is heterogeneous. So what is the diagnosis? Wow, pretty good. Synovial sarcoma. Synovial sarcoma doesn't mean the tumor around the synovial joint. It is totally different. It's not relating to the joint and not relating to the synovium, although the term misleading to a synovium. So synovial sarcoma is a sarcoma with 30% with calcification. So usually when we look at a tumor, we usually check for the plant film whether the tumor contains amorphous calcification or not. And the second, the typical synovial sarcoma usually have a lobulated cystic component with, like this, many cysts combined together. If the case with calcification is more difficult, okay? Synovial sarcoma, mesoid type. Last 2 cases, 41 years old woman, palpable mass in her left ankle for 3 months. Okay, that could be more typical. Here we can see the T2 facet with low signal intensity mass, T1. I think this could be T1 with GAD. This is T1. So with some degree of enhancement. But as we look at the low signal on T2 and majority of component of low signal on T1, so we will think about gout, tophus, solitary PVNS, fibromatosis, or anything else. But in In this case, usually when we look at the low signal intensity tumor, we should pull out the plan film to look at any calcification or high density soft tissue to rule out the gout. If it is not the gout, then the answer could be solitary PVNS or fibromatosis. But in terms of fibromatosis, usually the low signal is rock-like, like this. It is not like the fascicular sign, pepper-like in schwannoma or peripheral nerve sheath tumor. So those are fascicular signs with pepper-like low signal intensity spot. But here we can see it's a rock-like, ROD rock-like, combined together, fixed in a mass with just a few enhancement. That is typical for fibromatosis. And T1, it is not higher in signal, so it is not a melanoma. Okay, great. Difficult case. Let's shift to the answer. Okay, fibromatosis, right? Case 9, 16 years old boy, pain with swelling, maybe redness. That is a sign for what? In anterior tibial area of left lower leg, maybe just a few days, trauma 16 days ago, so 2 weeks, with skin wound, positive. So here we can see the skin lesions with a long extension with fluid containing irregular spaces. So here's the MR imaging, T2 weighted, T1 and with gap. So here we can see all the soft tissue changes, but more importantly, very eye-catching lesions that we can see between the muscle all the way around the joint, right here. So the answer is right. Necrotizing fasciitis, 85%. Get the correct answer. The last case, 72 years old man, palpable mass at right thigh for 5 years. Progressively growth recently. Okay, the point is growth. Okay, everyone should know this case. T2, facet. T1, here we can see, is a fat-containing tumor with soft tissue component. Right? And after gap, enhanced with heterogeneous signal intensity. So it could be a sarcoma. Is it a synovial sarcoma, melanoma, MFH, liposarcoma? Wow, all correct. Congratulations. Yeah. I want to put all this K to the national board. Yeah, if you like. Liposarcoma, mixed type. Thank you. Thank you so much for all your attendance.